Hi, this is the Modern Dental Assisting book, Chapter 50, Fixed Prosthodontics. So we start talking about fixed prosthodontics, which is also referred to as crown and bridge commonly. This is the replacement of missing teeth with fixed prosthetics. So that means that they're permanently cemented in place and they don't come out of the patient's mouth. So once the restoration is made, it's made outside of the mouth and usually in a dental laboratory, and it's cemented into the patient's mouth or bonded into the patient's mouth permanently, and it does not come out of the patient's mouth. So that's usually a crown or a bridge. That is done by a general dentist, or a prosthodontist is the specialist that concentrates on fixed and removable prosthetics. So fixed is the key word. So fixed meaning that it's permanently cemented in place and can't be removed by the patient. So the prosthodontist is educated and skilled in the restoration and the replacement of missing teeth. And that requires an additional 3 years of residency training in a university or hospital-based accredited program, and taking and passing a board certified examination. So they get educated and training for clinicians, researchers, and teachers in prosthodontics. Considerations for fixed prosthodontics are a patient's dental condition. If they're systematically evaluated before the prosthodontic treatment is initiated. So it's necessary for us to obtain a detailed medical and dental history and provide the team to obtain a detailed background of our patient for thorough intraoral and extraoral examination. To fabricate and diagnose, to fabricate diagnostic models and obtain current series of full mouth radiographic images, intraoral and extraoral radiographs prior to starting these procedures. Then the dentist will develop a restorative treatment plan that's suited for the needs of the patient. So there are indications or reasons that we would want to do a fixed prosthetic. If the patient has 1 or 2 adjacent missing teeth in the same arch, they would need to have healthy supportive tissues. The tissues surrounding the area that the restoration is going to be fabricated would need to be healthy and free of periodontal issues. They would need to have suitable abutment teeth present. So the abutment teeth are the actual teeth that are going to hold the restoration. So the natural teeth that are remaining in the mouth that the restoration is cemented or bonded to. And the patient needs to be in good health and want the prosthetic. So we need to make sure that we're not coercing patients into something they don't want. The patient also needs to have the skills and the motivation to maintain good oral hygiene. So we need to make sure that they're able to clean around the appliances or the restorations that are being placed. Contraindications to these fixed prosthodontic would be disease or missing supportive tissues. Like I said, they need to have good, healthy tissues. So if they were to have severe periodontal issues, we would not be able to place these items because of the bleeding and the inflammation would not be able to create a good, sound restoration for the patient. If suitable abutment teeth were not present, so the abutment teeth need to be strong with good supporting bone structure, not decayed, and able to hold the restoration. If the patient's in poor health or doesn't want the prosthetic, then that would be another reason not to do the procedure. If they have poor oral hygiene habits, so if they're not taking good care of their teeth, they're not flossing, they're not brushing regularly, the margins of these restorations still have the natural tooth at the margin, or where the restoration and the natural tooth meet. So if they're not brushing and flossing well, then the plaque and the calculus will build up around there, and they will get recurrent decay in that area, and it will break down very fast in that area, especially if it's an area that doesn't have any enamel and just the cementum or the root is exposed. So they'll get decay rapidly, and the tooth can break down, and they can end up losing that whole restoration. So we need to make sure that they do have good oral hygiene habits and they understand the importance of keeping these areas clean. Another reason would be if the patient can't afford the treatment. So there are different types of prosthetic restorations. So the first type that we're going to talk about is an indirect restoration. An indirect means that it is created outside of the mouth and then cemented or bonded into the mouth. So a direct restoration is something that is made directly inside of the mouth. So like a filling is a direct restoration because we take out the decay and we take the material and we place it directly into the tooth, and then the restoration is done. That is direct restoration. So an indirect restoration is when we prep the tooth, but let's say if we go with an inlay, the actual restoration is made in a lab outside of the mouth. So, and then it is cemented or bonded into the mouth. So if the restoration is designed outside of the mouth, it is an indirect restoration. So inlays and onlays, as well as indirect veneers, crowns, and fixed bridges are all indirect restorations. So that means that they are created outside of the mouth in a lab, and then they will be cemented or bonded into the mouth. An inlay covers part of the occlusal and proximal surfaces. So an inlay is like a filling, but it is made of porcelain or gold or a more sturdy material than what a filling would be made out of, where a filling is made out of a resin composite or an amalgam. So an inlay is just more sturdy, and it is going to be cemented or bonded in and made outside of the mouth, where the filling is directly made inside of the mouth. An onlay is similar to an inlay, where it covers proximal and most of the occlusal surfaces. So it just covers more area than an inlay does. Indirect veneers, what they do is they improve aesthetics. So they are made for the anterior facial surfaces. So indirect veneers are made at the lab, and then they are bonded to the facial surfaces of the anterior teeth. You can have direct veneers, which they are composite veneers, so they are like fillings that are made directly onto the teeth. But we're talking about indirect restoration, so these are veneers that are made outside of the mouth. Then you have crowns that cover the whole surface of the coronal portion of the tooth, which are made outside of the mouth, and they cover one singular tooth, or one unit is what it would be called, and they are bonded or cemented to the tooth. The next one is a fixed bridge. The fixed bridge traditionally is 3 units or more, and it is replacing one or more missing teeth. So why is it 3 units if it's only replacing one tooth? Well, that's because it has to sit on something, because it can't just float. So what it does is you have the two teeth on either side of the missing tooth that it connects to. So it sits on top of those two teeth. They're prepped down so that a crown can sit on top of the tooth on either side of the missing tooth. And then those are called abutment teeth. Those are where the abutment crowns to the bridge sit. And then in the middle is the pontic, which is the fake tooth that you are replacing with the bridge. All three of these crowns are what's called soldered together. So it is one piece of a restoration. So all three crowns are soldered together. So it is just one piece, but it's 3 units because it's 3 different teeth. However many teeth are included in the restoration, that's how many units there are. So even though we're only replacing one tooth, the bridge would be 3 units because it goes over 3 different tooth numbers. So indirect restorations are also known as cast restorations, and they are fabricated outside of the mouth. So the reasons that we would do a traditional crown would be to cover a decayed or a damaged tooth. So a tooth that has a severe amount of decay in it with a very large filling, or a tooth that was damaged. Maybe it was broken. You bit on a jawbreaker and broke your tooth in half, or someone was hit in the face from a car accident or a baseball and their tooth was damaged. So we would cover that tooth with a crown to protect it. The crown then covers the damaged or the severely decayed tooth. Now we don't leave the decay under it. What we do is we remove the decay and put a large filling there. But because the filling is so large, there's more filling than there is natural tooth structure, so it gives the tooth more of a chance to break. So because of the fragility of the tooth, we cover it in a crown to give it more strength. Crowns can also improve the aesthetics of a tooth because of discoloration, maybe because of a root canal or because of some kind of staining, internal or external staining. So we can put a crown on to change the color of the tooth. Also to protect, like I said, endodontically treated tooth. If the tooth had a root canal, after a tooth has a root canal, it becomes brittle because there is no blood supply to the tooth that has been removed because the nerve has been removed from the tooth. So we need to put a crown on that tooth to protect it and make sure it doesn't break or shatter. Also, if you have a dental implant put in place of a tooth that has been extracted or that is missing for some reason, the implant is in place of the root of the tooth, but you need to have an implant crown put on the top of the abutment to replace the tooth itself. So we have different types of crowns. We have a full crown. The full crown is going to completely cover the anatomic crown of an individual tooth. So the full, what you see where the enamel would cover the tooth is the anatomic crown. That is the full crown. 3/4 crowns cover the anatomic crown, except the facial portion is unchanged. So it doesn't cover the facial portion of the tooth, but it covers the other 3/4 of the tooth. This is seen often in pediatrics when they're doing anterior crowns. When I worked in pediatrics, oftentimes we would do stainless steel crowns on the anteriors, but we would cut out the facial portion if there was not decay there so that they didn't have to have the stainless steel crowns on their front teeth just for aesthetics. And then you can have an implant supported crown. It's an alternative to traditional crown. So instead of having the natural tooth there with the root that is supporting a crown, you would have an implant in the place of the root with an abutment on top of it, and then the crown sitting on the abutment that holds that in place, so it replaces a tooth that was extracted. Next, we have a fixed bridge. So I talked a little bit about a bridge earlier. These are recommended when either one tooth or multiple teeth are missing in the same quadrant. So with the components of a fixed bridge, which you need to know the components of a fixed bridge, each tooth that is part of the bridge is considered a unit. So if there's 3 teeth in the bridge, there's 3 units. It doesn't matter how many teeth are missing, it matters how many teeth are involved in the bridge. If there's 6 teeth involved in the bridge, there's 6 units. And that matters the natural teeth and the missing teeth, you count all of them together. Pontics are the part of the bridge that is replacing the missing tooth. So any missing teeth that are being replaced are called pontics, and any natural teeth in the bridge that are holding it in place are abutments. There are 2 types of bridge. There are resin bonded and implant supported fixed bridges. So with the resin bonded bridges, they are held in place, being bonded in place, resin bonded in place, or they can be implant supported where maybe you have 3 missing teeth, and instead of putting a partial denture there, you put in 2 implants and then put a bridge on the 2 abutments and then 1 pontic in the middle. That way, instead of doing 3 implants, you're only doing 2 implants and 1 bridge, and one bridge that's replacing one of the teeth. So here are some of the materials used in the fabrication of indirect restorations. So gold is also referred to as high noble. It is the most expensive material to be used. So if patients are requesting or the doctor is recommending gold, the restoration is going to be more expensive. They do use porcelain fused to metal and refer to it as PFM. What that means is there's a metal base to the restoration, and then porcelain is poured on top of it for aesthetics so that it looks like a natural tooth. The metal base just makes it a stronger restoration. And then you have porcelain or all ceramic so that you don't have that metal base underneath. You can have composite resin that is just made of that resin-based material, and then you can have zirconia. You can refer to figures 50.10 through 50.12 to look at the materials used in the fabrication of indirect restorations in your book. The role the dental laboratory plays is very significant when we're talking about indirect restorations. So first, the doctor has to write a prescription that is required before you can cast or fabricate an indirect restoration. So if an implant, a crown, a bridge, anything is requested from a dental laboratory, that is actually a prescription. So just like going to the pharmacy, you can't go to the pharmacy and say, hey, I don't feel good, I need an antibiotic. You have to go to the doctor and get a prescription and then get that from the pharmacy. So this is the same way with any of these indirect restorations. Is you go to the dentist preps your teeth and then tells the laboratory what they need through written prescription. The length of time to fabricate is a key factor in scheduling the patient's return date. So depending on what you're having made will depend on when the patient comes back. So if it's a crown that they're having made, it usually takes about 2 weeks turnaround time for your impressions to go from your office to the lab, have the lab make the crown, and then have them send it back to you. So you're not going to schedule your patient for at least 2 weeks to return to have that crown seated because it's not going to be back from the lab before then. So you have to make sure that the front desk knows how long in between appointments that the patient needs to be scheduled before bringing them back. With bridges, it could be 3 weeks. So it depends on what it is that you're having made, how long the lab is going to need, and you need to know what your lab time is, because different labs have different turnaround times. So with the crown procedure, it typically requires a minimum of 2 visits. The first appointment, you will do a shade selection, which is where you match the shade of the teeth that are in the mouth to what you would like your prosthetic to be. You will also take preliminary impressions with a bite registration, and the dentist will prepare the tooth. Then the dentist will take the final impression. You, as a dental assistant, can take the preliminary impression and the bite registration, but the dentist only can take the final impression. So in some states, you will be allowed to fabricate and place the provisional coverage or the temporary, but in some states, you will not be allowed to do that, and you need to know what your scope of practice is to see if you are allowed to provide these services. At the second appointment, the try-in, you will try the crown in. If it fits well, you'll do any adjustments that need done, and then the doctor will cement the crown because it is a final cementation. So with provisional coverage and temporary cement, in some states, you are allowed to cement that with temporary cement because it is not a permanent function. But at the second appointment, you are allowed to try the crown in and adjust it, but you are not allowed to cement it because it is a permanent cement. So when you're doing shade selection, the shade that you pick is going to go off the adjacent teeth because you're going to want it to match and look nice and uniform in the mouth. You're going to use something called a shade guide, and it has all the available options used to match the natural shade of the teeth color. So what you should do is moisten the sample that you are putting next to the teeth before you put it there, and always view the shade in a natural light. So maybe near a window, or if you have to, take your patient outside so that you can see it in natural light, because in fluorescent light, it's going to look very different. And then when the patient walks out in natural light, the colors are going to look very off if you're using it under the fluorescent lighting. The dentist reduces the height and contour of the tooth with rotary instruments, so the hand pieces. So when they're preparing the tooth, they're going to shave that tooth down on the occlusal and all around the sides of the tooth. That's because when you put a crown on the tooth, the tooth at the end has to be the exact same size as it was at the beginning of the procedure. So if we just plop a crown on the tooth, it's going to be way bigger and the bite will be off. The patient will be uncomfortable and nobody's going to be happy. So what we have to do is we have to prepare the tooth by using our rotary instruments and reducing the height, the contour, and the circumference of the tooth. So the casting will have the necessary strength and the correct size of the restored tooth. The gingival margins are designed to provide a smooth and strong junction at the edges of the casting with the surface of the tooth. So they need to be smooth, just like the edges of our teeth are now, so that when you go to floss around that restoration, it feels nice and smooth and you're not catching the floss and getting a bunch of food caught under there, which in turn will, in the long run, cause food traps, it will cause decay, and lots of problems for your patients. So margins are also known by several other terms such as bevel, chamfer, and shoulders. So sometimes crowns don't have enough to hold on to because so much of the tooth structure is gone. So that's because it's been extensively decayed in the tooth. tooth was broken, or maybe it was endodontically treated and a lot of the tooth structure is gone because of that. So there are different things that we can do. So if the tooth is extensively decayed, but it's still a vital tooth, meaning it did not have a root canal, so it still has the nerve, we can use a core buildup. And we can also use retention pins. So they're little pins that go down inside of the tooth that help to hold more material for the core buildup so that the crown has more tooth structure to hold on to, so that it's more stable on the tooth. If the tooth has been endodontically treated or has a root canal, we can do what's called a post and core, where that is a piece of metal that is actually fabricated at the lab that is cemented or resin bonded down into the tooth. And then the crown holds on to the post and core because it gives it more of a surface to hold on to. When we are providing these services, we need to make sure that we are watching for gingival retraction and tissue management. So with gingival retraction, what we do is we have to manage the bleeding and saliva. So we do that, one, with our suction, and two, with retraction cord. So we take the retraction cord and we displace the tissue with it mechanically. We put it in something called Hemodent, which is a hemostasis solution that makes the gums stop bleeding. So we soak the little piece of cord in that, and then that cord is packed around the gums to help widen the sulcus so we can get a better impression, and with no bleeding in the artifact of the impression. We can also have tissue management by surgical retraction, and that is surgically removing the gums with the rotary instruments or with hand instruments. For our final impression, for an indirect restoration, it has to be accurate and detailed. And remember, once again, the final impression must be done by the doctor. If it's defective, the casting will also be defective. So the crown or the bridge, whatever you're making, the inlay, the onlay. So the final impression has to be very specific. We're going to use elastomeric materials to create an extremely accurate impression. It's also necessary at this time to obtain a bite registration and an opposing arch registration, which oftentimes are done with wax bites or elastomeric materials. After that is done, we're going to create provisional coverage, which is our temporary tooth covering that's placed on the tooth after we prepare it and after the final impression is obtained. So the temporary is what is worn until the final restoration is returned from the lab and placed onto the tooth. So the reason that they're wearing this provisional coverage is to reduce sensitivity and discomfort. It maintains function and aesthetics for the patient. It's going to protect the margins of the preparation because those margins are important to keep intact. And it prevents shifting of the adjacent or the opposing teeth, because as soon as there's space in there, the teeth are going to start moving into that space if there isn't something there to hold that space. It's kind of like being in line at an amusement park and the person in front of you gets out of line. You're not going to just stand there and hold that space for that person. You're going to move up in line. So the teeth do the same thing. If there's a space, the teeth move up in line or move down, whatever the case may be. So we need to have that provisional coverage there so that it's holding that space until the permanent restoration is delivered and cemented or bonded in place. At that delivery appointment, before that permanent restoration can be placed, we have to remove that provisional coverage because it's going to be in the way. So we're going to remove the provisional coverage and make sure that all of the temporary cement has been removed. When the casting's been fitted and is acceptable, the dentist cements it to the tooth with permanent cement or it's resin bonded. You also want to check the shade before cementation. Make sure the patient is happy with the shade, not just you, because you're not the one wearing it. The patient is the one wearing it in their mouth every day. The cement is placed on the inside of the restoration and transferred to the dentist for placement. Now we lute it. We place it on the inside walls, not the occlusal surface of the inside of the crown. So we use permanent cement for this. And sometimes we do use temporary cement for this in certain cases. And in those cases would be if it was a tooth that was not endodontically treated, but was having symptoms, and we thought maybe it might need an endodontic treatment, we may temporarily cement a permanent restoration in that case to see if the tooth calms down over the next few weeks. If the tooth calms down over the next few weeks, we bring the patient back and then we just permanently cement the restoration. If it does not, then the patient has the root canal or the endodontic therapy, but you're able to easily access the tooth without having to make a hole in this nice new crown. Because if it was permanently cemented, you wouldn't be able to just so easily remove the crown, but you would have to make a hole through the crown to access it for the endodontic treatment. So instead of doing that, we just permanently or temporarily cement it, do the root canal, and then permanently cement it. Because sometimes teeth flare up and seem like they need a root canal, but once you put that permanent on there, they do calm down. Or sometimes they just have a lot of sensitivity with the permanent or the preliminary crown or bridge, and then once you put the permanent on there, things really seem to calm down for them. So you put the temporary on there just to make sure that everything's going to be okay, and give them a few weeks. With the bridge procedure, the preparation of a fixed bridge can be completed in 2 appointments, just like a crown. But the difference is, instead of prepping 1 tooth, you're going to prep 2 or more teeth. So it requires a longer appointment. Then you're going to have a try-in and cementation appointment. The casting is tried in and checked carefully to determine the accuracy of the fit, just like with a crown. And if it fits, you make the adjustments necessary and it's cemented into place. So it's just like a crown appointment, except that you're prepping more than 1 tooth, so it will be a longer appointment. Remember, the abutment teeth are usually prepared for a full crown or an onlay. And there are going to be the abutment teeth are the natural teeth, and the pontics are the fake teeth that are in the bridge or the teeth that are being replaced that are missing. When we talk about computer-assisted restorations, we have machines that are called CAD/CAM machines, and that means computer-aided design, computer-aided manufacturing is what CAD/CAM stands for. It's technology used to design the anatomic features, size, and shape of a tooth restoration. We can use them to design veneers, inlays, onlays, crowns, or bridges. If you refer to the figures 50.20 through 50.23 and procedure 50.4 in your book, it has information on assisting in a CAD/CAM procedure. So good home care is essential to the maintenance of a fixed prosthesis. It is essential that you go over how diligent a patient needs to be with brushing and flossing in these areas to make these restorations last for the duration of the patient's life or of the prosthetic's life. A fixed prosthetic and its supporting tissues must be brushed carefully each day. And if they have a bridge, they're going to have to use a bridge threader to thread dental floss under the pontic and into the sulcus at both abutments of the bridge. So the fixed prosthetics have to be taken care of just like normal teeth. And if the symptoms don't subside, they need to call the office immediately. So it's normal for patients to experience slight temperature sensitivity after the crown's been placed, but it should subside over time over the next few weeks or months. If it is not subsiding or it's getting worse, they should contact their provider so that they can come in to have the tooth evaluated. Thank you.